Good afternoon and welcome to SSMC Answers. My name is Matt Getman, Chief Medical Officer here at SSMC, and I'm thrilled to be the host of the program today. As many of you know, SSMC is one of the largest hospitals in the UAE and is a joint venture between the Abu Dhabi government and the Mayo Clinic. We are here to treat patients with serious and complex medical issues. We are here to also deliver comprehensive care that's directed to you, the patient. We want to deliver what we consider a holistic approach to care, where we consider the impact that each disease has on the mind, the body, and the spirit. In addition, we want to think about providing patients and family members alike with information on different disease states. What can they do to understand their disease? What can they do to prevent their disease? And how can they be in a position to best manage their disease? In each of our SSMC answer sessions, we ask an expert from our medical staff to join and talk about common medical issues. Today's topic is that of cardiology and specifically heart valve disease. And I'm thrilled today to welcome to the program Dr. Joe Maloof, who is our professor and chair of cardiology at SSMC, an international expert, and he's going to be answering many questions that we have about heart disease, specifically heart valve disease. Welcome, Joe, to the program.
Thank you.
Thank you so much. Please start by telling us a little bit about your background and then also your practice here at SSMC.
Okay. I'm originally from Lebanon, where I did my training at the American University of Beirut. And then I did my postgraduate training in the United States. And I've been at the Mayo Clinic now for over 30 years. So I'm a cardiologist. My interest is in valvular heart disease, and my training is also in imaging of valvular heart disease, specifically echocardiography.
Okay, so the echocardiography is looking at the kind of the function of the heart. Is that
Yes.
right? Yeah.
Yes.
Okay. So, and as part of the joint venture, we're so fortunate to have many of the staff. I mean, I'm a urologist at Mayo, you're in cardiology, and we're here at SSMC. Now, how long have you been here in Abu Dhabi at SSMC?
This is my 4th year.
Okay. And so let's start by just giving a general overview of the topic of heart valve disease. Now, as background, you know, the heart, 4 valves, but I'll let you take it from there. You're cardiology.
Okay. Well, as you said, there are 4 cardiac valves, 2 on the left side, 2 on the right side. And we can categorize diseases or valve diseases into 2 categories. Those that you are born with, the congenital ones, and those that you acquire. And they really differ in their presentation and the timing of intervening on them.
And what are the factors that cause the valve to not work normally? I mean, I can understand that it could be a congenital problem that you're born with, but what exactly is happening to the valve which is causing the problem overall with the heart?
Right. Well, the congenital ones are ones where you are born with a defect in the valve itself. So for example, with the aortic valve, normally you have 3 leaflets for the aortic valve. But when you're born with a defect in the aortic valve, usually it is either 2 leaflets or 1 leaflet, what we call unicuspid or bicuspid, as opposed to tricuspid or tri-leaflet valve in older people.
So every time the heart beats, there's coordination with the beat of the heart and the valves, and ideally the valves are going to open and move the blood through the different chambers of the heart and move the blood to the lungs and move the blood out. Is that the idea?
That's correct. That's correct. But problems arise when the valve either becomes narrow or starts leaking. And this is the usual problem that we face with these valves. And the valve can both leak and be narrowed at the same time.
And can all of the valves of the heart be predisposed to the similar sort of changes that are abnormal?
Yes, but the left-sided valves are under more stress, and therefore they are more prone to have problems as you grow older.
What makes the left side valves under more stress?
Because the left side of the heart is pumping against a higher resistance, which is the aorta, which supplies all the blood, the blood to the entire body. Whereas the right-sided heart valves are supplying or pumping blood or helping to pump blood into the lungs, which is a lower pressure sink.
Okay. So if you're thinking that someone has a problem with heart valve disease, what sort of signs or symptoms might someone have?
Right. The usual symptom for valvular disease is shortness of breath. Somebody who was exercising regularly and then all of a sudden starts feeling that they're getting short of breath with effort, that's one of the signs. Another sign might be symptoms that mimic blockages in the coronary arteries, what we call angina. And it depends on the valve. This is typical of what we call aortic stenosis. Narrowing of the aortic valve can produce symptoms that can mimic those of coronary artery disease. And then the third sign that can happen is blackout or near blackout with, for example, aortic stenosis again.
Now, if the pump is not working real well, is it sometimes patients might notice leg swelling or?
They might, but these are really very advanced symptoms. You don't like to wait until that point. You like to try to intervene much earlier before the pump that is connected to that valve starts failing. So when you talk about swelling in the legs, it could be a sign that the pump, in this case the right side of the heart, is starting to fail. And you don't want to wait until that point. The same applies to the left side. The main indication, or at least one would like to intervene on any of these valves before the pump starts getting weaker.
Okay, so the presentation is if you start to have this shortness of breath, of these spells, these episodes, then get to the doctor and be seen.
That's correct.
What sort of physical examination is done first?
Well, first of all, we like to take a good history, and it's very important to know exactly what's going on with the patient. Then, of course, we like to examine the patient, make sure what is the problem with the auscultation. We're using a stethoscope, the conventional stethoscope. And then after that, usually we request an echocardiogram, an ultrasound of the heart. And the ultrasound of the heart really is the key to establishing the correct diagnosis.
And most of the time, I'm guessing with listening to the heart, you're getting a good idea of what the general diagnosis might be.
Correct.
And that's because heart murmur,
That's
right?
correct.
There's different murmurs for different problems. Tell me about that.
Well, there are murmurs and there are murmurs. There are murmurs that are benign, murmurs of childhood, murmurs of adolescence, could be just simply benign findings.
When you say benign, it's not harmful.
Not harmful, nothing to do with any problem that will happen to the person. And there are murmurs that are significant, meaning that they suggest that there is a problem with the heart valves. And these are the murmurs that give us pause.
So some murmurs might be related to an optimally functioning pump, but many murmurs are related to a pump that's not working so well. And when I say pump, I mean the heart.
Pump or valve.
On the valve, okay, yeah, okay. All right. So now if you go to the echocardiogram, what sort of additional information will this give us?
It will tell us first of all, it will establish the severity of the valve disease.
Okay.
And then it will also tell us what is the impact of that valve disease on the underlying pump, the pump to which that valve is connected. Because as I mentioned before, you don't want to win a battle and lose the war. The war is the pump. If the pump dies on you, you can't replace it except with a transplant, as you know. So we need to make sure that we know for sure how severe the valve disease is, and then try to figure out when is the optimal time to intervene on that valve, if necessary.
So how is an echocardiography done? How is this procedure done?
It's done using ultrasound waves, and it's really a non-invasive test for the most part. And you just put gel on the body, and then we apply an ultrasound beam, and that interrogates the valves and the heart and feeds us back like a sonar. Returns back, the sound waves return back to the machine, and then we are able to see images of the heart valve.
Now, are there any sort of things that you need to ask the patient to do before you look at that picture? I mean, is there, you just do it normally, or do you ask people to exercise, or how do you prepare this test?
There are several types of echo. The standard one is called the transthoracic one. There's no need for any preparation. You can do it on the spot. But then if there is need for more advanced testing, such as what we call transesophageal echocardiography, which is essentially an endoscopy. You pass a probe into the mouth, goes through the esophagus, into the stomach, and we take pictures of the heart through the stomach and the esophagus. It's like the Hubble telescope, if you wish, for the heart, because it's very close to the heart through the esophagus or the stomach. Now, this needs preparation. Patient has to be fasting and so on. And then we have a third component, which is to put the valve to a stress test. And that's called hemodynamic stress testing for the valve. Hemodynamic valve stress testing. And essentially, it is like any engine. The valve is like any engine, or the pump is like any engine. And so a patient may not have symptoms while talking to you, but when they exercise, they might have symptoms, and you might need to stress them to see what really happens during exercise.
So these are all very specialized tests that we have. We have all of these at SSMC?
Yes.
Okay. In addition to the ultrasound, what is the role of other modalities? Is there a role for CT scanning or a role for MRI?
Sure. There is a growing role for both CT and cardiac MRI. For example, for the right heart pump, for the right side of the heart, cardiac MRI is the gold standard, and gives us more information than we get with an echocardiogram sometimes. So they're complementary tests. CT scan is also very important, particularly because with the valves, you can only, or the best modality to detect calcium and to quantify the amount of calcium on a valve is with the CT scan.
Okay.
But again, this requires a lot of expertise. It's not enough to have the equipment. You really have to have the experience in how to interpret the results that the equipment provides.
So now, of all of the different valves, what would be the most common valve that would need intervention?
The most common are the mitral leak through the mitral valve, and narrowing of the aortic valve. These are the most common that we see. But in essence, it's the aortic and the mitral. Both can either have a leak, or have a severe narrowing through them.
And it sounds like if it's caught early, you might not need to intervene right away.
If it's caught early, it is the timing for intervention can be determined, and at least you can plan it ahead of time. The main thing is to plan it in such a way that the pump function is preserved and doesn't fail on you.
So you don't want the heart to deteriorate.
That's correct.
Okay, keep the muscle of the heart strong.
That's correct, because that's the only thing that you cannot replace. You can replace a valve, you cannot replace a heart except through heart transplant.
So now, when we think about valve treatments, what are the different treatments? Let's say, if we talk first about mitral valve, what are the different treatments that are available for correcting mitral valve problems?
Now, as I said, most of the problems with the mitral valve have to do with the leak, with the leaking valve.
Okay.
And most of the times these valves can be repaired, either surgically or, if need be, with a catheter, depending on the case. For the aortic valve, if it is very narrow, increasingly we are using a catheter-based approach to replace the aortic valve. depending on the age of the patient and other factors.
So this is fascinating. This doesn't require any sort of incision like maybe had been done in the past? It can...
Well, increasingly we are avoiding surgery for the aortic valve. And so, for example, we now reserve surgical replacement of the aortic valve surgery with an open chest to those patients who are, for example, under age 65 with a 20-year lifespan. Then yes, but increasingly people are getting older, and therefore more patients are now eligible to having the catheter-based approach only, without surgery.
How long has this catheter-based approach for managing the valve been available?
Oh, it's been available for some time now, for many years, but the indications have evolved. Before, when it started, it was only applied to patients who were inoperable, who could not have a surgery, and therefore they were eligible for that procedure. But now, even for younger people who are operable, who are low risk, we sometimes offer them just the catheter-based approach.
It sounds like it would be a quicker recovery.
It is a quicker recovery. There are caveats to it. There are problems with it, like anything we do, because the valve that is implanted is a biologic valve. And this biologic valve, we don't have very long data on its durability.
So what happens then, if that valve doesn't
Fails.
work? Yeah, can you do another one of these endoscopic?
You can do, depending on the size of the valve that was placed, but you can do another valve inside that valve.
Oh my
what we
goodness.
call valve-in-valve implantation. So there are, the field of interventional cardiology has really exploded in the past 20 years.
Yeah.
Or 15 years.
Now, I'm a robotic surgeon,
Yeah.
and I have, of course, urology, but the other big area that I'm aware of in cardiac surgery is robotics.
Right.
Tell me about robotics in cardiac
Yeah.
surgery.
Robotic surgery applies mainly for mitral leaks. And as you mentioned, this has really taken off over the past 15 years or so. And we use it frequently if a patient has a specific finding in their heart, which is mainly limited to the mitral valve. And so it's an option that is great because, first of all, the hospital stay is shorter, and many patients, they do it and they're back to work soon after. So it is one of the options that we have now, one of the armaments that we have,
and
one of the tools.
With this robotic approach, is it more of a replace it or a repair of the original valve?
We try to avoid as much as possible replacing the mitral valve. So we try to repair the mitral valve as much as we can, especially that the most common problem is a leak through that mitral valve.
Okay. And then if people are going through these interventions, in general, what's the recovery like?
If they go for the classical open heart surgery, the usual hospital stay without any complications is 5 to 7 days. And really, it depends on how active the person was before going to surgery. So for example, in this, I'm always amazed in this part of the world because we see a lot of valve diseases in young people here, as opposed to in the West where the average age is 75 or above. And so we operate. The oldest person I know of, that patient of mine, who went for a TAVI, or for a catheter-based replacement, was 97. And I remember her sending me every Christmas thereafter for 5 years. She lived to be 102. So it depends how active you are. If you're very active before the operation, you recover much faster after the operation. This applies to any kind of operation.
It's worrisome to hear that valve disease has a different presentation maybe in this region than other parts of the world. What in general can citizens of UAE, do to reduce the risk of heart valve disease?
Well, let's start with the congenital ones.
Okay, now those are the ones you're born with.
You're born with.
Okay.
Some of them are as a result of consanguinity. So consanguinity is highly prevalent sometimes in certain societies, and that's one of the things that one has to avoid because they're inherited disorders. The ones that are acquired, really, unfortunately, nobody knows for sure why they happen. We attribute them to age, but with age, if you have high blood pressure that is not checked, if you have cholesterol, lipids that are not checked, not treated properly, any of the bad habits and lifestyle issues that are important to pay attention to should be addressed. But early recognition is the key thing.
So we talk a lot with the heart about heart healthy and lifestyle modification and so forth. If you have valvular disease, does that also apply?
Not as much as it applies to coronary artery disease,
Okay.
which is the number one killer and the number one disease in cardiology, probably in also any other field.
Now, what is mitral valve prolapse? We hear a lot about this. Yeah. People talk about it a lot.
Sure. Mitral valve prolapse is a congenital abnormality in the mitral valve, and basically the support for the valve is such that it allows the valve is a bit, I can't say it's weak, but it allows the valve to prolapse, meaning to rise above where it is supposed to be seated, and as a result, it's like a drawbridge. Instead of closing properly, it doesn't close properly, and therefore there is a leak that can be associated with it.
Do people that have mitral valve prolapse, are they predisposed to then developing problems that will require intervention?
Yes, because the support for the valve, the strut that supports the valve can sometimes break, and once it breaks, then the leak can become severe very suddenly. And therefore, people who have this condition can report all of a sudden waking up or feeling very short of breath.
Okay, some questions are coming in, so we'll go to the questions. The first question that's coming in, I think you've answered this, but let's just touch on it again. Is valve disease hereditary? Or yeah.
No, valve disease can be hereditary, but the majority is not hereditary, it is acquired diseases.
Okay. Another question is, what other medical conditions should I be concerned about with valve disease?
Well, one has to be concerned about having coronary artery disease in addition to the valve disease because you don't want to add insult to injury. And so coronary artery disease is something that one has to prevent or help prevent. But you have to look for that if you're dealing with valve disease.
So there's where, having the heart healthy diet and avoiding the fats and exercise and non-smoking and all those sorts of things would be beneficial for the valve patient.
Well, indirectly, because it helps with the coronary artery disease. And here, one of my favorite things is to emphasize, because I'm now living here, and I know in the whole Arab world, I see the shisha places and the hubbly-bubbly places, and these are worse than smoking. So, and I think this needs to be emphasized. It's not the cigarettes only, it's the cigarettes, the cigars, the hubbly-bubblies, and the shishas, and so on.
This is the good public awareness message, and probably the most important thing that a cardiologist should be saying.
That's
so,
correct.
And a physician,
and
right?
exercise regularly. I mean, if you want to stay healthy, talking about remaining healthy.
Now, one other question coming in are potential complications of valve surgery.
Yes, well, any intervention, whether it is surgical or non-surgical, is like a sword with a double edge. You always have advantages and benefits, and you can have the downside. So there are complications that can arise with any kind of intervention. And I think this is part of what we call the shared decision making, as you know, where it's very important. I'm glad you asked this question because patients have to be also, as you know, involved in their own care. And patients have to have insight into the problem. They have to know what are their options, what are the problems, what are the problems that can arise from any kind of intervention, and they have to weigh in the risks versus the benefits with the help of course, their provider. And one of the things that is, again, from my practice, whenever I lay it out for someone, I always chip in by saying, if this was my brother, my mother, my father, my recommendation would be to go that way. But it is ultimately your choice.
Absolutely. The shared decision-making is so important in everything that we do. Another question coming in, if my valve problem isn't serious, what do we need to do to monitor it over time?
Yes, well, depending on the problem itself, the monitoring could be as frequent as once every 6 months or 1 year, or it could be once every 5 years. It depends on the condition. But normally we would say once a year to at least check it out and then see if there's need for additional imaging.
And another question is, how will I know that my valve disease is getting worse?
Well, that's part of the follow-up.
Okay.
If you have no symptoms, that's part of the follow-up. But of course, if you have new symptoms that were not there during the initial evaluation, these symptoms should be reported immediately to your doctor.
Okay, and the last question I think we'll probably have time for today is, if I need to have my valve replaced, should I get a mechanical valve or a biological tissue valve?
Another very important question, and I'm glad you asked this question. The landscape of biologic versus mechanical has been changing very fast. So I would say that if you're, as cutoff, if you're under 65 with expected survival of 20 years, get a mechanical valve. If you are over 80, or if you have a expected survival of only 10 years, get a biologic valve. If you're in between, that's where shared decision making comes into the picture, and you have to really individualize the case and go case by case, and the patient has to have a say in whether they prefer one type of valve or another. Exceptions occur. If you're a young woman who wants to get pregnant, then you might opt for a biologic valve simply because this will avoid the need for taking blood thinners. But then the downside is that that valve will not last, and at some point it has to be replaced with a mechanical valve.
So just for the audience, can you tell us the difference generally about the biologic versus the mechanical?
The mechanical, as the term implies, is really a mechanical valve. It is very durable. Usually nothing will happen to it unless it gets infected or blood clots form on it because you're not taking your medications properly or they're not being followed up properly. The biologic valve is made out of different tissues. It could be cow tissue, it could be pig tissue, it could be human cadaveric tissue, and it is preserved in a certain way, and it's made into a shape of a valve to have the function of a valve.
And so since it's more tissue-based, then you don't need to be on the anticoagulation
Because
regimen.
of that, you don't need to be on the anticoagulation regimen that is very strict for mechanical valves. You might need it, but depending on other conditions that you might have, that may dictate the need to take a blood thinner.
This has been a great session today. Thank you so much, Dr. Joe Maloof, our professor and chair of cardiology here at SSMC, and a long-time staff member consultant at Mayo Clinic in Rochester. Great discussion today about cardiac valve disease. I appreciate you coming in. Thank you for answering all of the questions. And I know that this is going to be a meaningful impact to our listeners. Thank you so much.
Thank you. Thank you for having me.